everyone, and welcome back to today's episode of MedSynapse podcast series. I'm your host, Hetali Shah, and today we are diving into a critically important and timely topic, the intersection of diabetes and emerging infectious diseases. With the rise of infections globally, understanding how they affect vulnerable populations, especially those with diabetes, is essential. And to help us navigate this complex terrain, we have a very special guest with us today, Dr. Joseph Kunnirickal. Dr. Joseph is one of the pioneers in the diabetes management and in Dubai, a sought after speaker and the first obesity physician at a major hospital in Kerala. He has recently been recognized as the best diabetologist at the prestigious Economic Times Healthcare Awards in 2022. Currently, he is a specialist in internal medicine and diabetology at Zuleika Hospital in Dubai. Dr. Joseph's vast experience, including treating over 500 COVID cases and his expertise in COVID diabetes management, makes him uniquely qualified to today's discussion. So, Dr. Joseph, it is an absolute pleasure to have you with us, and welcome to the podcast today. Now, let's get started with our first question, Doctor. So, with the ongoing rise of emerging infectious diseases, how do you see the interplay between diabetes and these infections, particularly in terms of susceptibility to and disease progression?
That's a good question, Hetvi. We all know that the world faced a very uh, not so common pandemic in the form of COVID during the years 2020 and 2021. That was a big wake up call for many of the physicians like me and clinicians all over the world. What we saw was initially before the advent of the immunizations, we had a pretty surprisingly moderate to high mortality, especially among the elderly population during the first wave of the pandemic in 2020. If the audience recalls, it was the doctors in Italy who first did a postmortem on the vast number of cases who died, and they found microhemorrhages in the lung parenchyma, meaning it was causing bleeding in the initial phase of the COVID. And that is how anticoagulants was also used in the armamentarium against COVID in the later months. As people and doctors got to know more about the disease, we started using medications to prevent the bleeding when the patient is struck with the COVID virus. But the second scenario that emerged was we found that mortality and morbidity was higher in patients with uncontrolled sugars. That emerged around 6 months after the first case was reported. So for diabetologists like me, it was like a double whammy. We had to take care of the COVID. In cases with respiratory distress, we had to use steroid injections. Steroid injections by themselves increase the sugar values. And this was more confounding for us when it was a patient who already had type 2 diabetes. So the virus itself was increasing the sugars. The steroid medications we use for improving the breathing was also increasing the sugars. And we found the patients who had high sugars and who contracted the COVID virus without immunization, they progressed to a fast deterioration of their pulmonary function. Meaning it was those patients whom we had to put on ventilator if they were not responding to high flow oxygen. So we had to strike a very delicate balance. On one hand, we had to take care of the sugars. On the other hand, we had to make sure the virus was not causing further damage to the lung parenchyma. So when we encountered a new admission of COVID, and if he had a history of diabetes, we had to give simultaneously 3 or 4 shots of insulin daily in a basal bolus manner, give steroid injections to prevent the lung damage by the virus, at the same time give enough oxygen to prevent desaturation. So this was a wake-up call to show how important diabetes management was in the control of COVID diseases. I'm giving an example of a live infectious diseases cases where diabetes management was equally important.
Yes, actually, it is so fascinating, and it was actually a wake up call for a lot of physicians and patients as well.
Actually, this information of mine I published in the Week magazine under a topic called COVID and diabetes, where I show the correlation between worsening sugars and worsening prognosis in COVID. It was published in the health supplement of the National Magazine Week, sometime in 2022, I think.
Okay, it would be interesting for us to publish that as well on our
It
website.
is available in the net for anybody. Just search Dr. Joseph K.
Sure.
Joseph, COVID and Diabetes Week magazine. It's available for everybody to read.
Definitely, it would be an interesting read. So now speaking of the complexities, what have been some of the most significant challenges that you have faced in managing diabetes patients who contract emerging infectious diseases, and how do these challenges differ from managing the non-diabetic patients?
Well, to put it simply, now I'm in Dubai. Every month we have cases of influenza, we have cases of pneumonia. Of course, respiratory cases are more common during the winter months there. Now, suppose I admit a case of influenza or pneumonia and the patient is non-diabetic, the recovery is fairly faster, meaning they respond to the first dose or second dose of antibiotics given intravenously. And I don't face too much of complications in discharging them. But the same case, if he's having, let's say, an HbA1c of 9 or 10 or 11, 12, these are all uncontrolled diabetes. There is every possibility of the lung infection worsening, taking more time for recovery. They may require even basal oxygen, like 2 liters or 3 liters of oxygen per hour, to make sure that the pneumonia doesn't worsen and progress to a form of sepsis. This is not common just to pneumonia. If it's a urinary tract infection, if it is COVID, if it is influenza, any respiratory illnesses which is caused by a bacteria or a virus, a patient who does not have well-controlled sugars, it's always a headache for the clinician. Then what happens is we have to treat not only the infection, but simultaneously use short-acting insulin during each meal and a long-acting basal insulin at night to make sure the sugars don't exacerbate. Because sugar by itself is a nidus for infection. So a person with severe UTI or a severe lung infection won't make full recovery or good recovery until we give optimum control of the sugars. So for a physician, the moment we hear we have admitted an infectious case with uncontrolled diabetes or existing controlled diabetes, we are always on the guard. We make sure that the nurses check the sugars before every meals and morning fasting also. And we have to be prepared by giving insulin at all times, 3 to 4 times daily, and make sure the dietitian gives a diabetic diet that is in tune with the patient's requirements.
So it actually requires a holistic approach to treat diabetes as well as the infectious disease.
Exactly. There are doctors like me who manage my own diabetes in my cases, but those doctors who don't have the confidence or skill to manage diabetes can always give an endocrinology.
Yes, definitely. Now, though, given this bidirectional relationship between diabetes and infections, so are there any specific preventive measures or vaccinations that you believe should be prioritized for diabetic patients, particularly in context of emerging infectious disease? Like even we've seen for COVID that it was actually given priority basis vaccination for diabetes patients. So
Diabetes, like I told you, it is a progressive disorder that causes immunosuppression in vast majority of patients, meaning you become immunocompromised. So it's very essential that diabetes patients are given influenza vaccine shots or flu shots every year, and those above the age of 50 or 60 can take a yearly, once in a lifetime, like a pneumococcal vaccine. The benefits of taking these vaccines are, if you take the influenza vaccine and you contract, there are patients who still contract influenza after taking vaccine, as we have widely seen in the UAE. But the good thing is the patients who have undertook the vaccine, be it children or adults, the symptoms that manifest once you contract the influenza will be milder compared to patients who have not taken the vaccine. So diabetes patients, if they take the influenza vaccine yearly, it will definitely reduce the severity of symptoms if, God forbid, they contract the virus. Similarly, if they take the once in a life, the 23 antigen pneumovac vaccine, that will prevent the pneumonia from becoming complicated even if the diabetic patient contracts. So definitely, I would strongly recommend diabetes patients to take the yearly influenza vaccines because the antigen and subtype keep changing every year. So it's good to refresh the memory of your immunity by taking the influenza vaccine every year. And the pneumococcal vaccine can be taken once for life after the age of 50 or 60, which will prevent the development of severe pneumonia complications.
Yes, it is actually very helpful, especially, looking forward and trying to mitigate these risks.
Because India is the diabetes capital of the world, and Middle East also is one of the regions which has high incidence of diabetes cases. So in both these geographical regions, it would be very prudent if the clinicians advise the patients to take both the influenza and pneumococcal vaccines on a regular basis, which will prevent a vast majority of complex respiratory symptoms.
Yes, definitely. And now, as we know that antibiotic resistance is an issue that is only growing. So, how do you foresee the management of diabetic patients evolving, especially in terms of infection prevention and control?
That's a good question. See, in the UAE, we have a situation where the junior doctors and GPs they assume all fever, sore throat, and cough cases as viral, and they end up giving just a cough syrup and paracetamol and say it will recover on its own. The very same patient within 3 days they come to a senior clinician like me, and then I see the throat is all red and congested. The patient is having very high grade fever with chills, chronic. The cough is very bad. Cough is a big issue in the UAE, especially dry cough, because it's caused due to an allergic bronchospasm in the lungs. In such patients, if you go by the guidelines, yes, I agree. Antibiotic resistance is a big emerging problem all over the world, especially in the developing countries. But that doesn't mean antibiotics is like should not be given. To decide that, if you suspect it's a viral infection, you have to do three parameters like a CBC, CRP, and influenza test, rapid test. So that will give a clue if it is viral or bacterial. Suppose the counts is like less than 5,000. Let's say the WBC is 2,000, 3,000. Influenza antigen may or may not be positive. Patient is having high grade fever with chills, watering eyes, running nose. Then you can assume it might be viral because these are cardinal symptoms seen in viral infections. But suppose the WBC shows 10,000 or 11,000 with no evidence of any viral antigen being positive, then there is no harm in giving an empirical or prophylactic antibiotic like an azithromycin to see how the patient responds initially, and then escalate the antibiotics if the patient is worsening. There are cases where we give an azithromycin paracetamol and see that the patient is not improving, the CRP is rising. That means the patient is having a severe infection wherein we have to use higher grade antibiotics like an augmentin or cefurox. So my take on the matter is, I'm not saying out of 100 patients, all 100 should be given antibiotics. But if the clinician, like a GP or junior doctor, decides if it is viral, there has to be evidence to quantify it as viral. You can't just give a paracetamol and cough syrup and say, go, you will recover because it's viral. And then the same patient goes to another doctor within 3 days in a more, let's say, more bad, worse clinical outcome. So that conservative approach is not the right approach when a patient presents to you. You have to look at the clinical parameters like tachypnea, the grade of fever, the chills, how bad is the throat, whether the patient is having breathing difficulty. So all these factors should play in your mind when you decide to label it as a viral or bacterial infection. But yes, there are doctors, very many, who write antibiotics even for viral infections. That definitely in the future can cause antibiotic resistance and the complications that arises from that. So doctors should use their clinical acumen and judgment to decide if it is viral or bacterial before blindly labeling it as viral. That's what I'm trying to say.
Yes, actually, that is even sometimes very commonly seen these days that it is after a few days, it just again aggregates in such populations. So, yes.
I often encounter it in Dubai. Most of my cases are second reference cases. I see the initial doctor has given only a cough syrup and paracetamol. The patient has had worsening of the symptoms, which is how I am forced to introduce an antibiotic, then do lab investigation, chest X-ray, and then either I treat it on an OPD basis, and some bad cases I have to even admit for nebulization.
So it is actually very important to treat patients with such comorbidities differently than the normal
Exactly. You have to
population.
assess all the parameters before deciding if it is viral, bacterial, if you're admitting it or treating it on an OPD basis. It has to be a holistic, all-round approach.
Yes, definitely, I agree too. Now, given that emerging infectious diseases often disproportionately affect vulnerable population, including those with diabetes, so what steps do you think healthcare systems can take to better protect these high-risk groups during such outbreaks?
First and foremost, Hetvi, the control of diabetes is very important. There are many patients who take the same diabetes drugs for, let's say, 3 years, 4 years. They're not even checking anything. They don't know what is their HbA1c. They don't have a CGMS, continuous glucose monitoring system. They don't prick on their own and check the sugars. And they assume the drugs which they were taking for, let's say, 2 years ago, like a Janumet, a combination of sitagliptin metformin. They believe the drugs which was first initiated by the doctor will keep keeping their sugars under control lifelong, which is a false theory. First and foremost, patients should understand diabetes is a progressive disease, meaning the quantity of insulin secreted by your pancreas every year, especially if you have contracted it as a genetic basis or a family basis, it will keep decreasing every year. So the same drug that works initially in your system may not be working always. That you will only know by checking your A1C and FBS, PPBS values regularly once in 4 months at least, or do self-monitoring of glucose at your home using a glucometer, or using a CGMS system once a month for 7 days. This is the only way you can keep a track. Or Apple should invent a watch, which they are working on it with the Foxconn company, but it's a work in progress. Still, the Apple Watch cannot read your sugar readings directly, non-invasively. It is in the works. Maybe 2 years from now it will come. So when you have such mechanisms regularly, especially when you feel tired, you feel fatigued, you're frequently urinating, you're drinking too much of water, you're eating too much of food, that means there is some variations in the sugar values, or you're becoming thin very quickly. So unless your HbA1c is kept below 7, you are at risk for contracting all sorts of infectious diseases on a recurrent basis. For example, a woman who has an HbA1c of 10, she is going to have frequent UTIs. A male who has HbA1c of more than 10, he may have prostatic infections. He may keep developing URTIs. So he may keep having skin infections. So it is very imperative that a patient with diabetes should monitor the sugars regularly. He should have a proper diet with less carbohydrates in his diet. And compulsorily, he should have 30 minutes of exercise regularly. And he should take the flu shots and pneumococcal vaccine also. Unless he does these things, if he, God forbid, contracts, let's say, a COVID infection or an influenza or a pneumonia infection, he's going to have it really bad, meaning he will have very bad symptoms. He may have to be admitted, put on oxygen, given IV steroids, IV antibiotics, nebulization, and the doctors will have a tough time in controlling his infection just because the sugars is uncontrolled. So there is a direct correlation between keeping your sugars under check and reducing the impact of any infections that may emerge in the future. According to WHO, worse diseases are impending to attack the world, which is worse than COVID. So we have to be prepared. The Ebola virus is 50 times more lethal than the COVID virus. The hemorrhage starts within 24 to 48 hours. You will start bleeding from all over your orifices. So imagine if such a pandemic hits the world, what will be the state of affairs if a patient with diabetes does not have good control of it? I'm just telling a hypothetical example. Sugar management is something which Indian patients and Arab patients have to take very seriously.
Yes, I think also spreading the right awareness and taking the right steps to manage it is really important from the beginning.
Of course, because they have already, I think the monkeypox virus has already created some panic among the WHO officials and some health ministers and governments all over the world. In fact, even India has prepared a protocol to. I think today morning there was a news. They have isolated one patient in the AIIMS in New Delhi in the infectious diseases ward, suspected monkeypox. So as we grapple with more emerging zoonotic diseases all over the world, as the man forest cover is disappearing all over the world, especially in my home state of Kerala, we are seeing amoebic encephalitis spread. We are seeing Nipah virus spread, especially during the monsoon. So this is all showing a disappearing boundary between man and the forest. So what diseases were confined to animals are now spilling over to the mankind. So we have to be doubly careful. which is why most of the countries they have now started super specialization in infectious diseases, including in India, DM in infectious diseases. So this is because we are facing diseases which we have not even treated before. All these diseases like COVID, monkeypox, we don't have wide exposure to these diseases. First time we are hearing it. Before, when I was a student, we used to read these diseases in Robin Cook medical thrillers. Medical thrillers, Robin Cook, the Congo virus was the villain in one of the novel called Virus. It was a blockbuster novel then. Now, what we read in the novel is happening in real life. So the least we can do is, observe precautions, wear a mask, wash your hands regularly, keep your sugar and pressure and cholesterol under control, not just diabetes. Other parameters are also important. And keep yourself healthy. Basically, boost your immune system. Take multivitamins. This is all the message I can give to my peer group and patients.
Yes, actually, that is such a good piece of advice for everybody, I would say.
And please, to the patients, do not self-medicate by deciding the antibiotics on your own. I always tell my Dubai patients, you can take an antihistamine, you can take a paracetamol, you can take a cough syrup, you can take a gastritis capsule, but please, please don't decide the antibiotic on your own, because you are not visualizing your throat, you're not hearing or auscultating your chest, so you don't know what infection you are having. So please don't take azithromycin or augmentin or cephalosporin on your own. But unfortunately, many patients do that. And within the third day, they are in front of my desk with severe symptoms and no relief. So don't do self-prescription of antibiotics on your own. That's why we doctors are sitting both at India and Dubai to help you guys out.
Actually, that is so true that you mentioned. So now, doctor, before we wrap up, I'd like to ask one last question outside the main topic. You
Yeah.
had such a distinguished career, particularly with your recent recognitions. So can you share with us what inspired you to pursue a career in internal medicine and especially diabetology?
That's an excellent question, very close to my heart. See, many of my followers don't know I was a law student once upon a time. People who have noticed my talks know that I love speaking. I am into oration because in school also I was a public, that was my hobby. I was a 3-time literary champion and best actor. So what happened is, after 1 month of law school in Kerala, I was a little scared of what the political outfits, student political outfits are very active in Kerala, especially in law colleges. So I was scared by all the violence and, I was too young. I was not mature enough to face all those kinds of things. So suddenly I thought only medicine is best for me, though I was skilled in speaking and public speaking. Even now I love reading current affairs and all those things. But somehow in my mind, I felt medicine is a respectable profession, or engineering is the profession that will give us a good livelihood, etc. So maybe it was an impulsive decision, and I joined for medicine in Nepal. I did my undergraduation in Nepal. After that, I was influenced by 2 doctors in Cochin, one of whom he was my relative, Dr. Paul Puthuran. At that time, he was the most famous physician in Cochin. And another doctor, Dr. Anthony Tachila, was also, they were both among the best physicians in Cochin at that time. And I knew both of them closely because my first boss after I finished MBBS was Dr. Anthony. So perhaps these 2 doctors inspired me to take up internal medicine. Second thing is, I am a big Sherlock Holmes and Hercule Poirot fan. Meaning, I love reading crime stories, and even now my favorite genre of movies is crime fiction. So internal medicine is one specialization where you have to take a proper history. You have to really, you are given clues by the patient, the history, what profession he is, where ethnically he is from, whether they have a good relationship with the spouse. Every single question is important in internal medicine. So because Sherlock Holmes and Hercule Poirot solves cases by the questioning line, perhaps that's what inspired me to like internal medicine. Because internal medicine also, the best way to treat the patient is taking a good, proper, long history. And there are patients who get stunned when I ask them, are you an engineer? Are you from Kerala? Are you from Kashmir? Because without them telling me, I tell those things. Because from their body language and the way they speak, it is already evident to me from where they are. We observe everything, the name of the person, the body language, when they walk in, how they walk, their dressing, everything gives us a clue. So that is primary one reason why I like internal medicine. They have to be open to us, they have to be frank to us, then only we can help them. And I get to talk to different type of people being an intern.
True.
So that is
was so inspiring actually, and to get to know how you actually are so much into it. So it is really inspiring.
For me, I study the psychological profile of the patient also. Sometimes patients they tell multiple complaints together. Then I know it is not just an organic symptom. It is something to do with the mind also. So then I ask them, "Are you okay with your
Mhm.
husband? Are you okay with your children?" Then she starts crying.
Oh,
Then that is the clue. They have some anxiety problems or mentally they're not sound. Not in a bad way, not in a deep way. They just need some counseling. So those patients I refer to my psychiatric colleagues after I do my treatment.
yeah,
So
actually.
a good clinician should always study the mental profile also of
Mhm.
the patient, even if it is an internal medicine patient.
Yes, that is so rightly said that it is so important for healthcare professionals also to rightly communicate with their patients.
Because these problems are very prevalent among the medical community themselves. As you know, the recent Calcutta case, we all face a lot of pressure, a lot of tension. So I tell my friends, please don't internalize all these things. If you face
Mhm.
problems, you either tell us or go to your psychiatric friends. They are also your friends. They will help you out. Don't think of any stigma in taking those kind of medicines because those are also medicines at the end of the day.
Actually, that is very rightly said and pointed out. So, as we conclude this session, Doctor, I would like to thank you so much for sharing your insights and expertise with us today. And let me tell you, this has been an incredibly informative discussion, and I'm sure our listeners have gained a lot from this.
Thank you so much, Hetri.
And to
Thank
our
you.
audience, thank you so much for tuning into today's episode of MedSynapse podcast series. And remember, if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. It is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay informed and stay healthy.